Well, welcome back. This session is devoted to diseases of the pulmonary circulation, and here's a list of the topics that we're going to cover. I'm going to spend most of my time on pulmonary edema and pulmonary embolism, and we'll look more briefly at pulmonary hypertension, and then finish with a few words about cor pulmonale and arteriovenous malformation. Now, pulmonary edema is a very important topic. It's not a disease in its own right, but it accompanies many forms of lung and heart disease, and it can be lethal. And so it's important that we understand the pathophysiology of this condition. And it's defined, if you like, as an abnormal accumulation of fluid in the extravascular spaces and tissues of the lung. That's a fancy way of saying that the fluid should be in the pulmonary capillaries, and if it leaks out, then that's pulmonary edema. So let's start with our old friend here, the electron micrograph of a pulmonary capillary. Here's the lumen here, of course, and that's where the fluid should be, but it can either leak into the interstitial space or even into the alveolar space, and that, of course, is pulmonary edema. Now let's look at the components of the blood-gas barrier, which of course are important in maintaining the integrity of the barrier and its function. And here we see a very high-power view of a section of the barrier. We've actually seen this before. This is the slide we saw just previously, and it's been turned on its side, and the microscopist has chosen an area of the blood-gas barrier there and enormously magnified it here. And I can see, and maybe you can, that the bar here is only 0.4 of a micron, so we're at a very high magnification. And we can see very clearly the ultrastructure of the alveolar epithelium here, the extracellular matrix, and the capillary endothelium here. And at first sight, these cellular layers don't look all that different. In this particular image, the endothelium is a little bit thicker than the epithelium, and it contains more vesicles, but basically the two cellular layers look rather similar. However, this is misleading because their functions are very different. Their permeabilities are completely different. The capillary endothelium is highly permeable to water, solutes, ions, and even some proteins. As we'll see, some albumin can move through the capillary endothelium. But by contrast, the alveolar epithelium is extremely impermeable to water, solutes, ions, proteins. In fact, the epithelium actively pumps water from the alveolar space into the interstitium using a sodium-potassium ATPase pump. So the epithelium is in the business of keeping the alveoli dry. Now, of course, it's true that there is a thin layer of surfactant on the alveolar epithelium, but this pump actively transports water from the alveolar space into the interstitium. Now, the reason why the functions of these two layers are so different perhaps can be illustrated if we look at the intercellular junctions of the two layers. Here we see an intercellular junction of the capillary endothelium, and you can see that it's made of two cells just butted together. And it's easy to imagine that materials can move fairly easily from the capillary lumen into the interstitium here. By contrast, if we look at the intercellular junction for the epithelium, we see it's completely different. It's a bit like two layers of Velcro stuck together. It's long, as you can see, and looks very tight, and that is consistent with what I indicated before, and that is that the permeability of the alveolar epithelial layer is very, very tight. It's impermeable to water, to solutes, ions, all proteins, as I said, and it actively pumps water from the alveolar space into the interstitium. Now, we can't get very far with a discussion of pulmonary edema before we come across the Starling Equilibrium. And this is shown here. This is a cartoon showing the alveolar wall here with the alveolar gas on both sides of it here and a pulmonary capillary in the alveolar wall. And the forces tending to move the fluid out of the capillary are the hydrostatic pressure in the capillary minus the hydrostatic pressure in the interstitium, Pc minus P sub I. Okay? Those forces are opposed by the colloid osmotic forces. In particular, the colloid osmotic pressure, indicated by the Greek letter pi, the colloid osmotic pressure in the capillary minus the colloid osmotic pressure in the interstitium. So you've got these two sets of forces. Now there's one complicating factor here, and that's indicated by the Greek letter sigma here. If the capillary endothelium were truly semi-permeable, that is to say it didn't allow any of the protein to move out of it, then sigma would be 1. The forces would be just a simple subtraction of the two forces. But in fact, the capillary endothelium is partly permeable to protein. Now, what proteins are we talking about here in terms of osmotic pressure? Well, you may remember back from your physical chemistry that osmotic pressure is determined by what's called colligative properties. That means the number of particles. And the number of particles of albumin, the number of molecules of albumin, it's much greater than that for globulin, because although the concentrations of the two sets of proteins are not all that different, albumin is a much smaller, much lower molecular weight, and so there are a much greater number of albumin particles. And so it's the albumin that's chiefly responsible here. Now it turns out that as I said, the endothelium is partly permeable to albumin, and that's why we have to include this sigma factor here. Sigma is called the reflection coefficient. It's a measure of the ability of the capillary endothelium to prevent the passage or reflect the albumin molecules as they bump against the interior of the capillary wall here. So the complete equation is shown down here. It's the forces tending to move the fluid out minus the forces tending to move the fluid in, but we have an indication here of the reflection coefficient, and then the constant here is called the filtration coefficient. Now that's a very important equation in principle. In practice, it's somewhat limited because we're rather ignorant of some of the values here. Let's look at them. The capillary hydrostatic pressure, we believe, is probably about halfway between the pulmonary arterial and venous pressures. In fact, there's some evidence that much of the pressure drop in the pulmonary circulation is in the capillary bed. Also, there is a substantial difference in capillary pressure from the top to the bottom of the lung because of the hydrostatic gradient. The hydrostatic pressure in the interstitial space is not known with any accuracy, although there are some measurements that suggest that it's very low, maybe less than atmospheric pressure. The colloid osmotic pressure in the blood is known, 25 to 28 millimeters of mercury, but the colloid osmotic pressure in the interstitial fluid is uncertain. The value of sigma is about 0.7. And the net result of all this is that there is a continuous small loss of fluid from the interior of the capillary into the interstitial space. Probably only about the lymph flow from the lung thought to be about 20 mils per hour. It's a relatively small amount, but it's a continuous loss of fluid from the capillary into the interstitial space. Now, that's a very important point, because what that means is that whenever we disturb the equilibrium here, for example, we raise the pressure in the pulmonary capillary, we're going to increase the amount of fluid coming out of the capillary. And that's nicely shown by an experiment that was done a few years ago, where the lymph flow from the lung was measured in an animal preparation, and this is lymph flow here, in mils per unit time, and here's hours along this axis here. And at this point, these are the control measurements here, and at this point there was an infusion made of either saline or dextran. And you can see that immediately there was an increase in lymph flow. And that indicates, as we said before, that whenever you raise the capillary pressure, fluid moves out of the capillary. You can see that the increase lasted much longer for dextran than for saline, and that's because when the saline was infused, it very quickly moved out of the circulation into the interstitial fluid, whereas dextran, having a much larger molecule, remained in the circulating blood volume for a much longer time. Now, that's an interesting point, and there's a historical point here that I'm just going to make briefly, and that is that when I was a medical resident, admittedly a very long time ago, we believed that the capillary pressure in the lung could be raised to quite high levels before any edema occurred. And the reason why we believed that, why I was taught that, is that we saw patients with mitral stenosis, which was a relatively common disease in those days, who had very high pulmonary capillary pressures, but no evidence of alveolar edema. Now, the mistake that we made, or the mistake that was made, was that we did not recognize interstitial edema. By edema, we meant alveolar edema. But we now know that that was a misconception, and that as soon as the pressure rises in the pulmonary capillary, the amount of lymph flow increases. Now let's talk about the two stages of pulmonary edema. First of all, we've got the normal situation here, and you can see the artist has very nicely drawn a capillary. We've got the thick side of the blood-gas barrier here and the thin side here, and he's put in the pressures responsible for the movement of fluid. And under normal conditions, as we've seen, a small amount of fluid moves out of the capillary, finds its way through the interstitium of the alveolar wall, and eventually ends up in the perivascular and peribronchial spaces of the lung, which is where the lymphatics are located, and eventually the fluid moves out of the lung as lymph. Now suppose we raise the pressure inside the pulmonary capillary. In that case, we're going to increase the rate of egress of fluid, and actually the artist has drawn a slightly thicker blood-gas barrier here, which is exactly what happens. On the thick side, the blood-gas barrier expands somewhat as the fluid moves out, and now we see the fluid moving through the interstitium, and we get these cuffs of fluid around the small arteries, veins, and airways, and that's called interstitial edema. At that stage, there is no edema fluid in the alveoli. But then later, if we raise the capillary pressure even more, we increase the rate at which the fluid moves out, and now some fluid may spill over into the alveolar spaces. What exactly causes the fluid to spill over is not fully understood, but I suppose that if the pressure in the interstitium rises high enough, then we're going to damage the alveolar epithelium, and fluid is going to move out. I believe that whenever we have alveolar edema, there is damage to the alveolar epithelium, and part of the evidence for that is that the alveolar fluid always contains red blood cells. So that suggests that the barrier is damaged, and as we said before, the normal barrier is very impermeable to fluid, so that makes a lot of sense. So you get both alveolar edema now and, of course, interstitial edema as well. Now, how does the fluid move out of the lung? Well, it moves along what's called the interstitium of the lung. Here's a very old diagram, but it's quite useful because it shows the interstitium of the lung, the perivascular and peribronchial spaces, and you can see the lymph glands here, and that's the way the fluid moves out of the lung. And here's a nice image of a small pulmonary vein, and if we look closely, we can see the potential perivascular space. It's very small. It normally doesn't contain anything at all. It's if you like the potential intrapleural space, which contains essentially nothing under normal conditions. This is the perivascular space, and it will contain fluid if there is interstitial edema. And I'll just remind you, as we talked about in the session on the pulmonary circulation in the respiratory physiology series, that there are two types of blood vessels in the lung. There are the alveolar vessels, which are mainly the capillaries exposed to alveolar pressure, and there are the extra-alveolar vessels, which on the one hand are being pulled open by the radial traction of the lung parenchyma around them, because these vessels are running in the parenchyma, in the alveolar tissue. And on the other hand, they tend to close because they've got elastic tissue in the wall and also smooth muscle with tone. So the caliber of these vessels is determined by a balance between those two forces. And I think you can see that the pressure in this perivascular space is going to be low. It's rather like the sump of a car engine where the oil collects. This is a sort of sump, if you like, of the lung. And that's the reason why, if we get interstitial edema, we get a cuff of edema fluid around a small blood vessel in this case, in fact 2 of them here, or a small airway. Get these perivascular cuffs. So that's what happens in interstitial edema. Interstitial edema does not cause much change in pulmonary function, as we'll see in a moment, and it's actually difficult to identify in a patient. It's difficult to know whether a patient's got interstitial edema, and the people who are going to tell us are the radiologists, because they are able to pick up signs of interstitial edema. These are called septal lines, and they are horizontal, white, short lines here perpendicular to the pleural surface. And here are a few examples here. These are formed by the edema of the interlobular septa, the thickened interlobular septa. Now, I'm sure you're not going to be very impressed by that radiological appearance, so if you're in doubt, the best thing is to ask a friendly radiologist to help you. Alveolar edema, of course, is quite different. Here's an example of early alveolar edema, an electron micrograph, and you can see the capillaries here and some edema fluid around them here. The capillaries, incidentally, don't contain red cells because this preparation was made by fixing the lung by infusing fixative through it. And here's a light micrograph showing much well-developed alveolar edema. And you notice that the alveoli are either full of edema fluid or empty. In other words, the alveoli fill in a sort of quantile fashion. And they're either full or they're not, there's no edema fluid at all. And of course, you can also understand that this kind of condition is going to be very serious for the lung. It's going to impair gas exchange, because if we had blood flow through some of these edematous areas, of course that's going to represent a shunt and cause hypoxemia. It's very easy to pick up alveolar edema on a chest radiograph, and here's a rather florid example here, but it's usually easy to pick it up. You've got this bilateral shadowing here. Sometimes people refer to this as a bat's wing or a butterfly wing appearance, and it's usually quite easy to pick up alveolar edema. Now let's talk about the pathogenesis of pulmonary edema, and I'm going to do that by using the Starling Equilibrium. And the commonest cause of pulmonary edema is an increase in pulmonary capillary pressure. And examples of that would be myocardial infarction. With a heart attack, the left ventricle fails to pump the blood as it should. There's an increase in left atrial pressure, pulmonary venous pressure, and therefore capillary pressure, and there may be very severe edema. In fact, the patient may cough up large volumes of pink frothy sputum, and he may in fact drown in his own edema. So myocardial infarction can be an example. Another example is hypertensive left ventricular failure. In systemic hypertension, the left ventricle can often just cope with the increased afterload for a period, and then suddenly it'll fail and you can get a fulminant pulmonary edema. A very different situation is mitral stenosis, where the narrowing of the valve, the stenosis, occurs over many months or even years. And therefore, the fluid coming out of the capillary, of course, increases over this time, but there's no alveolar edema. However, there's extensive interstitial edema. And the reason why there's no alveolar edema is not fully understood, but apparently what happens is there is an increase in the number and the caliber of the lymphatics in this condition, and that prevents and that allows the edema fluid to be removed from the lung. Transfusion overload, which sometimes occurs during an over-enthusiastic transfusion in the intensive care unit, is another cause. And a rather unusual disease, pulmonary veno-occlusive disease, where the veins are diseased, is also an example. Now, the second most important cause probably is increased capillary permeability. And that's where the capillary wall is abnormal. And therefore, the filtration coefficient's increased, sigma is decreased, in other words, much more easy for the proteins to get across, and there's a change also in the colloid osmotic pressure of the interstitial fluid, which gets more protein. And there are a number of causes of that, including inhaled or circulating toxins. An important cause is toxic gases. Chlorine gas, for example. Every now and again, somebody is exposed to chlorine gas in an industrial setting and develops pulmonary edema. A very important cause is the adult respiratory distress syndrome, where, and we'll be talking about that later on when we talk about respiratory failure, and in that condition there is a big increase in capillary permeability, which causes edema to occur. Radiation of the lung is another cause of increased capillary permeability. Of course, if you're radiating a breast cancer, you try to protect the lung, but sometimes the protection is not adequate, and where the lung is radiated, you tend to get edema. Oxygen toxicity, where a patient in the intensive care environment is given too high a concentration of oxygen for too long a period, can cause pulmonary edema. And one of the important features of edema caused by damage to the capillary wall, that is a high permeability edema, is that the edema fluid has a high protein concentration. Whereas in the previous type of edema, that is just an increase in pulmonary pressure itself, pulmonary hydrostatic pressure, the filtration characteristics of the capillary are preserved, and the protein and the edema fluid has a relatively low protein concentration. However, I should say that that is the classical view, and we're now beginning to realize that if you raise the pressure in the pulmonary capillaries, initially you get a low permeability edema, but if you raise it high enough, you damage the walls of the capillaries, and therefore you can get an increased capillary permeability. So there is actually a spectrum of types of edema when you raise the pressure in the pulmonary capillaries. Another possible cause is a decreased interstitial hydrostatic pressure. Now, whether that is really the cause or not is a little bit iffy, but it is certainly true that if you have a long-standing pleural effusion or a pneumothorax where the lung is collapsed at a very low volume and you rapidly expand it, you can get edema on that side. And this is a unilateral pulmonary edema, very unusual. If you see unilateral pulmonary edema, you raise your eyebrows because that's something unexpected. But that can occur in this situation. Whether this kind of edema is really caused by a reduced interstitial hydrostatic pressure is uncertain, because there's some evidence that the edema fluid is of the high permeability type, and therefore the capillaries are damaged. A decreased colloid osmotic pressure is usually not a cause of edema in its own right, but it can certainly exaggerate any other cause that's present. And this can occur, for example, with saline overtransfusion, which can occur in the intensive care unit, for example, or in diseases where there is hypoproteinemia. They would be diseases, liver diseases and renal diseases could cause hypoproteinemia. Lymphatic insufficiency is a rather uncommon cause, but does occur. In silicosis, for example, the silica particles are very toxic. They're picked up by the macrophages, which enter the lymphatics perhaps, and the macrophages die and they plug up the lymphatics. So that sometimes occurs. Lymphangitis carcinomatosa, where you get carcinoma cells plugging up the lymph vessels, is another example. And lung transplantation, you get pulmonary edema, but and of course there are no lymphatics that are transplanted, but there it's an immunological problem probably. There are some types of edema where the cause is uncertain. And I'm going to say a few words about one of those. That's high altitude pulmonary edema, because it's a very interesting topic and it's only been sorted out in the last few years. Turns out that when people go to high altitude, they may develop high altitude pulmonary edema. It's actually a potentially lethal condition, and incidentally the treatment is to come down as quickly as possible. But the cause of this high altitude pulmonary edema has been a mystery, because although we know that there's a strong association with a high pulmonary artery pressure, the wedge pressure is normal. In other words, there's no left ventricular failure, so it's not left ventricular failure. So why would a high pulmonary artery pressure caused by the hypoxic pulmonary vasoconstriction, why should that cause pulmonary edema? And a very important and rather enterprising experiment was done a few years ago when actually a couple of friends of mine went to high altitude, set up a clinic at a very high altitude, and treated climbers with pulmonary edema as they came down. As they came down, these climbers would say, can you help me with my pulmonary edema? They would say, yes, I can, but do you mind if I bronchoscope you first? So they bronchoscoped these people at an altitude of about, I can't remember exactly, 14,000 feet or so in this tent. And what they found was something very important, that the edema fluid was of the high permeability type with a very high concentration of large molecular weight proteins. And here's an example of the data they showed. Here's HAPE here, high altitude pulmonary edema, very high protein concentrations, see a log scale here. In ARDS, which we often think of as the best example of high permeability edema, the protein concentrations are really not quite as high, and here we are at sea level and acute mountain sickness here. So what this meant was that for some reason, when the pulmonary artery pressure was high, the capillaries had damage to their walls, or some capillaries. Now, how could that be? Because we believe that the constriction of hypoxic pulmonary vasoconstriction is upstream of the capillaries. And then it transpired that there's evidence that the hypoxic pulmonary vasoconstriction is uneven, and that where there is constriction of the smooth muscle, the capillaries are protected, of course, from the high pulmonary artery pressure, but where there is no constriction, the capillaries are exposed and that their walls are damaged. And in fact, if in animal preparations you raise the capillary pressure to an unphysiologically high level, here's the capillary here, the alveolar space here, this is the alveolar wall here, you can see that, here's the wall of the capillary, I should say here. You can see a break in the capillary endothelium, and that's an example of the ultrastructural changes that occur under these conditions. Why do the capillaries break? Because the stress in the wall becomes so high. Remember that the blood-gas barrier, the wall of the capillary, is fantastically thin, and therefore an increase in pressure in this very thin wall is going to cause an extremely high stress. It's Laplace's formula, and that's one reason why the stress increases. The other is that if you go to an abnormally high lung volume, you can also increase the stress. Now let's move on and talk about the clinical features of pulmonary edema, and one of the most important features is dyspnea, shortness of breath. All patients with pulmonary edema are short of breath. They also have orthopnea, in other words, when they lie supine, the shortness of breath is greater, and they may develop what's called paroxysmal nocturnal dyspnea, where they wake up in the night feeling desperately short of breath, and that's probably because they slip down. It's probably because fluid collects in the lung as they slip down from their pillows. Cough is seen in pulmonary edema, and initially it may be dry, but then the patient may cough up pink frothy sputum, pink because the alveolar edema always contains red blood cells, frothy because of the surfactant. If you listen into the chest, you can hear crepitations, crackles on auscultation, particularly at the lung bases. And as we've seen, the radiograph shows septal lines in interstitial edema and blotchy shadowing in alveolar edema. The reason for the dyspnea is not fully understood, but very likely it's the juxtacapillary receptors that may be responsible. The endings of these receptors are in the alveolar wall, which becomes edematous, and they presumably are stimulated by this, and they cause this rapid, shallow breathing, the dyspnea. Now, interstitial edema has very little effect on pulmonary function. There's a little bit of evidence that lung compliance is reduced. The evidence is not all that strong, but probably the lung becomes a little bit stiffer. But there is evidence that both airway resistance and vascular resistance are increased, and probably this is because of the perivascular and peribronchial cuffing that we saw earlier on. And here's a diagram just showing how this could occur. Here you've got a potential perivascular or peribronchial space. This is either a blood vessel or an airway, it doesn't matter. And you've got the radial traction pulling it open. And now if you get edema fluid filling this potential space here, because that's where the lymphatics run, then you get a reduction in the lumen of the blood vessel or the airway, and that causes either an increased vascular resistance or an increased airway resistance. Now, alveolar edema causes much bigger changes in pulmonary function, in fact, dramatic changes. The first thing that happens, or one of the things that happens, is that the lung compliance is reduced. The lung becomes very stiff. And you'll find that in patients, for example, with ARDS, the adult respiratory distress syndrome, you need large pressures to expand the lung because of the edema fluid. Airway resistance is increased, partly because of the mechanism I just described, but also because there's a lot of edema fluid in the airways themselves. Gas exchange is seriously compromised. There's always severe hypoxemia due to both a shunt, as we saw, if you have blood flow through those alveoli that are filled with fluid, of course that's a shunt, and that's part of the ventilation perfusion inequality. Typically there's no CO2 retention. The PCO2 is normal, possibly because of stimulation by those juxtacapillary receptors. Pulmonary vascular resistance is increased, as I indicated earlier on. Now that's all I'm going to say about pulmonary edema. Let's shift now to pulmonary embolism, which is another very important disease. And one of the reasons why it's important is that it's very frequently overlooked. You've got to have a high level of suspicion of pulmonary embolism under a number of circumstances. Of course, as we'll see, if we've got a massive embolism, there's no problem there. But many patients with pulmonary embolism, the diagnosis is missed. The commonest cause is that there are venous thrombi in the legs, the lower extremities, and these are detached and they move up into the lung. You can also get thrombi in the pelvic area and also the right heart, particularly with atrial fibrillation. There can be emboli in the right heart. Mostly it's venous thrombi that are responsible for embolism, but occasionally you can have fat, air, even amniotic fluid that can cause embolism. Now, what's the pathogenesis of the thrombosis that occurs initially and eventually causes the embolism, or may cause the embolism? Well, there are three categories. One is stasis of blood, and that can be caused with immobilization. For example, a frequent cause is a patient who has broken a leg, for example, and is in a long plaster, and the leg is immobilized, and that tends to cause venous thrombosis in the leg. Venous obstruction is another case. If you're wearing something tight that obstructs the leg, or if the leg is up against an obstruction of some kind, and incidentally, immobilization and venous obstruction can possibly occur during long flights in the economy section of an aircraft, although there is some question about that, but it makes sense that that's a lot of immobilization, and there can be venous obstruction against the chair, against the seat, and that could cause it. Other causes of stasis are heart failure and also dehydration. There can be an increased coagulability of the blood. That occurs in some diseases, sickle cell disease. It occurs, for example, polycythemia can cause this. In fact, at high altitude, when you get polycythemia, there's a concern about pulmonary embolism. Malignancies can do this, oral contraceptives can, and unfortunately there's no really reliable test of this increased coagulability. And finally, you can get an abnormality of the vessel wall. Trauma can do this if the leg is banged in a football match or something, and inflammation can cause it. Although when you've got inflammation, then the clot, the thrombosis, tends to adhere to the vessel wall. It's less likely to cause an embolism. As I said, leg thrombosis is often unsuspected. There may be a bit of swelling, there may be a bit of local tenderness, and if you dorsiflex the ankle, pull the ankle up, sometimes there is pain in the calf, and that is some evidence. And there are techniques, venography, radioactive fibrinogen, impedance plethysmography, that can help in the diagnosis of thrombosis. When the embolism actually occurs, the thrombus is swept up into the pulmonary artery, it usually doesn't completely block the artery. But it certainly causes a great deal, enormous reduction in blood flow, of course, distal to the embolic area. It may deplete the surfactant in the embolized region of lung, and that can cause some atelectasis. You know, surfactant is turned over very rapidly. So if the surfactant is depleted, then you can get local atelectasis. People used to talk about infarction. Maybe that does occur from time to time, but probably what we see is really atelectasis in this region of the lung. Remember that the bronchial circulation is always available, even if the pulmonary circulation is obstructed. The eventual fate of emboli, if the patient survives, is that they're removed by lytic components in the blood. And it's very remarkable that after several weeks following an embolus, there may be no evidence of obstruction at all. Now, the clinical picture of pulmonary embolism depends very much on the size of the emboli, and I'm going to look at three sizes: medium-sized, massive emboli, and very small emboli. And medium-sized emboli are one of the commonest kinds. Those are the kinds you get when a patient is put into bed following an accident with a long splint or something like that, immobilized, and the patient suddenly develops some kind of pulmonary problem. And you need to be suspicious of pulmonary embolism, otherwise you're going to miss it. Occasionally the patient will have pleuritic pain and dyspnea. Well, the pleuritic pain, of course, is obviously it's going to give a suggestion that they may have an embolus. There may be a cough with blood-stained sputum. Sometimes there's a mild increase in temperature. Occasionally there's a pleural friction rub that you can hear by auscultation, but if the patient develops a pleural effusion, this will go away. The radiograph is often normal, but occasionally you can see an area of reduced vascular markings. Now, it's got to be a very good chest x-ray to show that, but sometimes that can be seen. And the key thing is an abnormal lung scan. The gold standard is angiography, but angiography is invasive and often is not required if the lung scan is clearly diagnostic. And here's an example of a lung scan showing multiple pulmonary emboli. Here's a scan following, I think, the inhalation of radioactive xenon in this case, showing normal ventilation throughout both lungs. But now look at what happens when you inject radioactive albumin. Then you find that there is a tremendous reduction in blood flow at the apex and base and the left lung here, and there are clearly abnormal areas on the right lung here as well. So this patient has multiple pulmonary emboli. Massive emboli occasionally occur, and that's a very different clinical picture. There's sudden hemodynamic collapse because the cardiac output is greatly reduced. There's shock, pallor, maybe central chest pain. Loss of consciousness. There's systemic hypotension. The pulse is rapid and weak. There's signs of right ventricular failure. The neck veins are engorged. The ECG shows right ventricular strain, and there's a fairly high fatality rate. Occasionally, with a massive embolus, it's possible to do emergency surgery and remove the embolus, but the death rate with this condition is high. Repeated small emboli is a different kind of clinical picture. These are frequently unrecognized. In fact, I would say generally unrecognized is what I would say. And the pulmonary capillary bed is gradually obliterated by these small emboli. And often the presenting problem is evidence of pulmonary hypertension. Patient may have dyspnea on exertion. Occasionally you can feel a right ventricular heave because of enormous increase in the right ventricle hypertrophy. There's a loud pulmonary second sound, and the ECG and radiograph confirm the right ventricular hypertrophy. So these patients sometimes come along with unexplained pulmonary hypertension, and the answer turns out to be repeated embolism. A word or two about pulmonary function in embolism. Of course, the pulmonary circulation has a large reserve, and small emboli, therefore, are not recognized in terms of functional changes. You can remove one lung from a normal subject with normal lungs, and there's essentially no increase in pulmonary artery pressure at rest. On exercise, there will be an increase, but the pulmonary section has a large reserve because of the abilities of the capillaries to recruit and distend. Occasionally, we see pulmonary edema with pulmonary embolism. That's not common, and if it occurs, it's presumably because of the same mechanism that I referred to in high altitude pulmonary edema. And that is to say, if you get a very high pulmonary artery pressure in the non-embolized region of the lung, then the capillary pressure increases and causes edema. The embolized region may develop atelectasis, as I said before, because of surfactant depletion. In fact, if you do experiments in animals where you embolize a region of the lung, then after a couple of days you can see atelectasis. Also, immediately after the embolic event, you can see an increase in local airway resistance. That's caused apparently by the low PCO2 in the embolized area, because there's so little blood flow there, acting directly on the smooth muscle. But this is apparently not seen in humans, because one of the features of pulmonary embolism, of the scan for pulmonary embolism, is that there is a mismatch between the blood flow and the ventilation. And that's an important diagnostic point, because if the patient has an area of emphysema, for example, both the ventilation and the blood flow will be down. So this occurs in animals, this acute increase in airway resistance, but apparently does not occur in humans, although, of course, in humans, we're always looking at the event much later, hours later, so perhaps that's the reason. Gas exchange is impaired in pulmonary embolism. You get hypoxemia because of ventilation perfusion inequality, and you can get a shunt with large emboli, possibly because of edema. And here are a couple of distributions. They're pretty remarkable that anyone was able to make these measurements. These are distributions of ventilation perfusion ratios in 2 cases of massive pulmonary emboli. And you can see several things. First of all, the distributions, of course, are grossly abnormal. Large amount of ventilation to high VAQ units. That's the embolized area being ventilated. That's dead space. And in fact, they measure the dead space here, and it's very, very high, as you can see. But in addition to that, there are large shunts. The shunt here is 20% of the cardiac output, here 39% of the cardiac output. So of course these patients have very, very serious lung disease, and pretty remarkable that they were able to measure these distributions. Now let's say just a few words about pulmonary hypertension. And here's a classification that's often given. It can be caused by an increased left atrial pressure, for example in mitral stenosis. The left atrial pressure is increased, and therefore pulmonary venous pressure, and therefore pulmonary artery pressure is increased. And perhaps I should have said, pulmonary hypertension here, of course, means an abnormally high pulmonary artery pressure, normal value of about 15 millimeters of mercury, and that's the definition of pulmonary hypertension. An increased blood flow can cause an increased pulmonary artery pressure that can occur on exercise. A lot of people don't realize that if a normal subject exercises at a high level, there's a substantial increase in pulmonary artery pressure. Pulmonary vascular resistance can increase as a result of either vasoconstriction, as in alveolar hypoxia. We mentioned the increase in pulmonary artery pressure at high altitude, for example, obstructive, as in thromboembolism, of course, and obliterative, as in emphysema, where many of the capillaries are destroyed. Primary pulmonary hypertension is a relatively uncommon disease, but recently there's been much more interest in this. Its cause is, says here, uncertain. I would say in most cases unknown. Although in some instances there is a genetic component, and that's something that's been described relatively recently. As I said, occasionally it's due to repeated small emboli. The population that, in which this is mostly seen are women between 20 and 40 years of age. You get dyspnea on exertion and sometimes syncope because the cardiac output is reduced. There are signs of right ventricular hypertrophy because of the hypertension, the increase in right heart. Sometimes vasodilator drugs such as sildenafil can help, and this is one of the reasons why there's so much interest in the disease at the moment, in spite of it being a rather uncommon disease. There's a lot of interest by the pharmaceutical industry in finding new drugs that are going to help, because the prognosis of this condition is poor, and it would be very important to try and find ways of helping these patients. If the cause is repeated emboli, occasionally these can be removed by surgery, and that's important. Here's an example of an abnormal pulmonary artery in primary pulmonary hypertension. Looks terrible, doesn't it? It's called a plexiform lesion. There's an increase in smooth muscle here. The media is increased, the intima is increased. Obviously, a very dramatic change in the pathology of the artery. Copulmonale, we won't dwell on this. It's defined as right heart disease secondary to lung disease, and we've mentioned it already in the context of COPD and in interstitial fibrosis. The pulmonary hypertension is caused by obliteration of the capillary bed. It occurs in both COPD and in diffuse interstitial pulmonary fibrosis, or hypoxic vasoconstriction, and possibly polycythemia in patients with COPD who develop increased hematocrits. There's a question as to whether this is really right heart failure, because actually the heart is operating high on the Starling curve, and the cardiac output can be increased on exercise. But that's not so important. Finally, let's a word or two about arteriovenous malformation. This is an abnormal communication between a branch of a pulmonary artery and a vein. It's something you're born with, and many of the patients have other evidence of vascular abnormalities, telangiectasies of the skin or mucous membranes. Sometimes there's a family history of this condition. If you've got a large communication, of course you've got a substantial amount of pulmonary arterial blood, mixed venous blood, joining the pulmonary venous blood. That's a shunt, and that can cause hypoxemia. It's one of the classical causes of hypoxemia caused by shunt. Sometimes a bruit can be heard over the lesion by auscultation. Finger clubbing occurs, and now it's possible in some of these patients to obstruct the shunt by inserting a blocking device, some wires, and that can be done, and that's useful. So that's all I'm going to say about diseases of the pulmonary circulation. They're very important, particularly pulmonary edema and pulmonary embolism are particularly important. And I'll leave it there. Hope to see you next time.